I think in the interest of time, we'll go ahead and get started. I want to welcome everyone today to this lunch symposium on behalf of Abiomed around ECpella therapy. I'm Sanjeev Agarwal, and it's really my distinct pleasure today to introduce our speakers and panelists. We will have joining us virtually Professor Potapov, who's the chair of MCS at the German Heart Institute in Berlin. We have Professor LaRusso, a past president of ELSO, and also cardiothoracic surgeon from Maastricht University in the Netherlands. And finally, Dr. Alan Gass, professor of medicine in New York Medical College and section chief of heart failure at Westchester Medical Center. The cadence today, we will have Dr. Potapov first presenting virtually. We will then go to a bit of a moderated Q&A, and then we'll take questions at the end. We do have two mics set up in the audience, and so please, I would encourage all of you to come and ask your questions, and we'll reserve some time at the end for that. So with that, we'll go ahead and get Dr. Potapov queued up and get underway. Thank you.
Good afternoon, ladies and gentlemen. I'm really glad to be here in this meeting. Sorry not to be physically with you, but I just followed the meeting. It's a great meeting. I'm very honored to be with you there. My topic today is cardiogenic shock and escalation to ECpella. So the mortality in cardiogenic shock is very high, and it is very interesting that European Society of Cardiology upgraded the use of mechanical circulatory support in cardiogenic shock to class 2A. It should be considered, and even the inotropic and vasopressors are class 2B, and this goes through all the types of cardiogenic shock. For example, acute decompensated heart failure class 2B, and also management of patients with pulmonary edema, the class 2B. It is class 2A, while the loop diuretics are class 2B. So it's upgrade in the last 5 years from class 2B to class 2A for mechanical circulatory support. So there are a lot of temporary mechanical circulatory support, but very important news is that IBP is not more good, and that it's 2B or even class 3. It should not be used in patients with cardiogenic shock. So in our institution, we have Impella 5.5, Impella CP, and peripheral ECLS. We use also ECpella. ECpella is the combination of Impella and ECLS, and we have increased use of this combination. So which type of device should be used in cardiogenic shock? If you go from A to E, from bottom to top, in patients in A at risk, non-mechanical circulatory support is necessary. However, if we are in the stage B, Impella CP is a very good solution as to transfer the patient to the other hospital, or just to stop the cardiogenic shock, to treat cardiogenic shock, to stop the spiral. And in stage C, D, and E, we have to use a full support devices like Impella 5.5 or ECLS. And in patients in stage E, extreme, the ECLS is first line, but then we, in our institution, we upgraded to ECpella to unload the left ventricle. So the use of Impella in Germany is increasing. You see the number last year is approximately 450 devices, Impella 5.5 and 5.0, so surgical implanted Impellas. In our institution, we see the same situation. So this year it will be over 100 surgical implanted Impella in our institution. The tendency is increasing. How to implant Impella? Axillary artery is most common access, especially for 5.5, because femoral artery is not possible for 5.5. In my opinion, my experience, the right axillary artery is much easier than left axillary artery. Of course, theoretically, carotid artery is also possible. Never use this access. And direct implantation through ascending aorta. We did it very, very small number, maybe below than 10 devices implanted through ascending aorta via graft. So you need hybrid operating room or fluoroscopy. I very recommend to implant Impella 5.5 using fluoroscopy because it is not always easy to visualize the Impella wire in the left ventricle. So CT scan is nice to have. And if you have some problems, some difficulties, just direct aortography in the OR. It's very, very helpful. So how does it look like in Zetos? So you see here in the middle is the artery. It's very easy. If I'm surgeon, I'm very easy. I do not think, I just do something. So in the middle is the artery, the plexus is above, and the axillary vein or subclavian vein is below. So graft 10 millimeter in diameter or 8 millimeter in diameter is sutured to the axillary artery, and then to outside, far away from the wound. So, but who needs more than Impella? And this is a very important question. And this picture shows you who needs more than Impella. And it's two group of patients who suffered from cardiac arrest and was resuscitated in the index admission. It means maybe a ROSC 2 hours ago, 3 hours ago. We speak about hours, not 1 week ago. But a ROSC some hours ago, they patient do very, very bad on Impella. You see the left line, they are very bad on it. They do not survive on isolated Impella. And patients with high lactate, over 8 millimole per liter, they do not survive on isolated Impella. They are too deep in cardiogenic shock. So they need something more than Impella alone. And what is it? ACLS. Well, the second possibility to implant ACLS in these patients, and you are very familiar with ACLS, and no need to explain you what is it. And ACLS has a lot of advantages: percutaneous implantation bedside under running CPR, available in peripheral hospitals, support up to 8 liters. 10 liters, it's very, very seldom, but usually maybe 7, 8 liters possible, depends on cannulas. And blood oxygenation and decarboxylation, also possible. Transport on ACLS, very good. So it's a lot of advantages. However, many disadvantages, like bleeding on the implantation site, cerebral hemorrhagia, a lot of artificial surface, wound infection, bloodstream infection, and very important complication, lung edema, because ACLS load the left ventricle. The left ventricle, the left ventricle does not eject against 8 liters of ACLS. So it is distension of the left ventricle, lung edema, and after half an hour of lung edema, you cannot recover lungs anymore. It's gone. So you can't forget the patient. And next point is complications. They occur increasingly rate after 2, 3, 4 days. So after 1 week, you have to do something. You have to decide to remove ACLS, to transit the patient to the next treatment, but you have to do something with this ACLS. So taken together, high complication rate and weaning should be performed between 5 and 10 days. So what is the solution? And the solution is the ECpella. It is a combination of Impella and ACLS published by my friend, Dr. Papalardo, 5 years ago. How we do it in Berlin? In Berlin, we use ECpella 2.0, single arterial access. And this picture shows you my first patient. You see here, Impella implanted through the graft to the axillary artery, and then it was not enough. So I decided to implant ACLS. So I implanted just the cannula, ACLS cannula into the graft, and venous drainage is here on the right femoral vein. So it was my first patient. So, but then I recognized that it's a fabric graft. It's possible to use this graft. So I use this graft like here. The one branch is for Impella implantation, and second branch from the ACLS cannula. So it's able to implant 15 up to 19 French cannula, depends on the size of the vessel. I usually implant 15 French is enough for 5.5 liter flow on the ACLS plus 5 liter on Impella. So you can achieve with this configuration up to 11 liters flow. It is a true 11 liters because you see it on the vasopressors requirements. It's gone. It's no need for vasopressors immediately. So you need even some drugs to decrease the blood pressure. So you see here this right side ACLS flow 6 liters and Impella flow 5 liters makes 11. It's optimal flow for patient in after CPR, optimal flow in patients in deep cardiogenic shock and SEERS and vasoplegia. So how to do it? This is a video shows you the implantation of ECpella 2.0 single arterial access. This is a graft, as a vascular graft, femoral, it's an axillofemoral crossover bypass graft. You have to cut it, of course, accordingly. It's no need to use this long graft. So the preparation of the axillary artery is as usual, and you should be careful about plexus, not to damage the plexus. So this is the artery in the middle, heparin up to ACT to 200, and then suture measurement of the length of the graft. It should be outside of the wound. So this is the length. Then the preparation of the graft. Important is that the tip of the cannula is behind the anastomosis. Otherwise, it's not possible to make it dry, the anastomosis, because the pressure of the tip of the cannula is 400 millimeter of mercury. So no one surgeon will be able to suture anastomosis and keep it dry with pressure of 400 millimeter of mercury. So the tip of the cannula should be behind the anastomosis. So how does it look like here? So clamping of the artery and performing of the anastomosis. So it's a very easy. I use glue to make sure, because the patients are in shock. It is sometimes difficult to achieve hemostasis. So tunneling to outside of the graft. And then implantation, first implantation of Impella, otherwise you cannot pass through. And the implantation of Impella, it's very easy. It is the same as usual. It's no real challenge here. And wire in the left ventricle, you pass the aortic valve, then implant Impella over this wire. Put the Impella into the left ventricle and start the support. So the patients now it's somehow stabilized with 5 liters. So, and afterwards, secure the Impella in place. So it's a very important because implantation of the cannula may move the Impella one or other direction. And then pass the arterial cannula over the wire. It's very important to do it over the wire, not to damage the vessel. So pass the cannula the second branch, put the cannula very deep to pass the anastomosis. And over the wire on the X-ray control under fluoroscopy. And then just connect to the tubings, and then put the cannula into a femoral vein, and this is the connection. Put the cannula into femoral vein, and then connect to the circuit of the ACLS and start ACLS. So now we have support with ACLS. It is 5-6 liters, and then Impella is as a vent. So fixation and close the wound. So it's not necessary to reopen the wound to remove all the systems. I will show you how to do it. So we have now 5 liters flow on ECLS, and we have 2 liters flow with Impella as a vent. It's just venting. So the explantation is very easy. Bedside, so remove the ECLS cannula from the branch. It's no need to sedate the patient, just remove the cannula. Of course, ligation. The Impella is still working, is in situ, and then I give blood back through the venous line, and then remove the venous line and manual compression and put some sunlight there. So it is very easy to de-escalate these patients. So the next step in development is ECpella 2.1, single arterial access and mobilization. You see the venous line implanted through right jugular vein. So the patients could be mobilized and walk around. So it is, you can do it later on, maybe in 2-3 days if it's necessary, but mostly you will remove SLAS, de-escalate this patient after 2-3 days. So this is the advantages of this ECpella 2 plus single arterial access. And very interesting, all the discussions about paraplegia on ECpella, it's maybe, I did not see ever in this constellation ECpella 2 plus, and we have now over 50 such patients. So maybe because it's no damage or no thrombosis of Adamkiewicz arteries. So these are results with ECpella 2 plus in our institution. We have over 50 patients, 52 patients. Look at these numbers. Mean lactate is 130 milligram per deciliter. It's over 13 millimole per liter. CPR was performed in 1/3 of these patients. And post-cardiotomy cardiogenic shock, high mortality, we all know this, it's 1/4 of the patients. So in 83 patients could be recovered. Some of them are palliation because of brain damage, whatever, some are on wish. And altogether, we have recovery from initial shock and multi-organ failure, 73%. De-escalation, so removal of ECLS, was performed in 60% of patients. So they are out of multi-organ failure. And almost 50% received further treatment. If you add the 6 patients with palliation who did not want any treatments, are awake and decided not to go to the next step, so you will have success rate up to 60%. So, this is very important. Look at this number, 160 milligram per deciliter is a median lactate in this patient. So, and this picture shows you that in our institution now, 50% of patients receive durable mechanical circulatory support from Impella or ECpella. So 50% have previous mechanical circulatory support, and survival of these patients from Impella to durable support is over 90%. So they are well prepared for the next step on Impella. So we have our algorithm for patients in severe cardiogenic shock. It is institutional algorithm. So we have here, of course, enter criteria. So this score is over 20, and metabolic decompensation, lactate. So we have points where the patient do not go to the next step. It is pH and presence of non-cardiac disease with very poor prognosis, and so on and so on. So, and then if it's not the case, we go to the next steps, and the algorithm is built on the left side. So if you look on the left side and you see no, 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 no. So for example, mechanical aortic valve, you cannot implant Impella. So yes, we go to peripheral SLS. Ongoing CPR, if you remember these two populations, patients with CPR and with high lactate. So under ongoing CPR, it's not possible to implant SLS single lateral access because you cannot make the anastomosis with under heart massage. So go to peripheral ECLS and then upgrade to ECpella within 2 hours. Status post CPR, ROSC, go to ECpella. If it's not the case, it's no biventricular affair and so on. So lactate is below 8 millimole per liter, go to Impella alone, isolated Impella. If lactate is below, it's lactated over 8, go to ECpella, and so on and so on. So below is a vasoactive score, how to calculate vasoactive score, and in case of stent in the aortic arch, Impella implantation should be performed through femoral artery. So this is algorithm just taken together as a piece, if you want to make a picture. Then what happens if you follow this algorithm? This picture shows you the result of the following the algorithm. We followed this algorithm since almost 3 years, and the green line shows you the survival. The red line shows you the patients who did not follow by the algorithm, who did not adherence to algorithm. Unfortunately, we have approximately 50% of our patients who was treated not accordingly to algorithm. Depends on the surgeon decision, individual decision, or whatever it is, or I was in holiday. So the survival is very bad. If in patients who are treated accordingly to algorithm, the survival is 50% better, for 30% up to 50%. And the same for Impella. Of course, it is a bias because now we do not implant isolated Impella in very sick patients, but we have survival 75% on isolated Impella. It is much better. The green line compared to implantations before algorithm, it is much better compared to patients treated without algorithm. We develop now the same, or based on this algorithm, we develop algorithm for post-cardiotomy cardiogenic shock. And it is the same idea to rule all problems out, and if it's not any problems, then it's possible to implant isolated Impella, but majority of the patients should be treated with ECpella. So, of course, the patient should be weaned after, and we have special algorithm for weaning from Impella. So, how to explant Impella? The first option is bedside explantation in local anesthesia, just to shorten the graft and put it below the skin, and we use this technique in our institution. The second option is to reopen the wound and just completely remove the graft and perform the reconstruction of the axillary artery with bovine pericardial patch. So, but we prefer very fast and easy explantation on a bedside. So, in conclusion, axillary implant and Impella is the first choice for patients with severe cardiogenic shock, and algorithm-based approach for escalation and de-escalation improves survival in patients with severe cardiogenic shock. Thank you very much for your attention.
Dr. Potapov, thank you. And if you could stay on the line for the Q&A at the end. One question I wanted to put to Professor LaRussa. Professor LaRussa, you've published extensively on the topic of LV unloading during ECMO. And I know we've seen from work from Truby and others the idea of sort of micro or subclinical LV distension. So could you comment first on the timing of LV unloading? And number two, what are the clinical indicators that we should be looking at for the need for unloading?
Okay, first of all, thank you Thank you again for the invitation here, for this nice session, and I congratulate Professor Potapov for the nice presentation. And well, I must confess one thing, that unfortunately it's because of us, cardiac surgeons, that we were not convincing enough about the knowledge of left ventricular unloading. We know that since decades that we are in the operating room, the heart is not doing fine. What do? We just unload the ventricle, we stay on pump with very empty heart, we reperfuse the heart without making enough work, but just resting. And then after a few minutes, sometimes even 20, 30 minutes, we try to go off bypass. So the issue of unloading for cardiac surgeons is known since decades. So why wasn't this concept not translated or not, let's say, proposed during or to the ECMO community? That is a little bit a question to me, I don't know. But about the importance of unloading for heart recovery after an injury is well known. So when to apply that? Immediately. So in my point of view, whenever you start ECMO with a myocardial injury, you should put as much as you can at rest. So this means that you have to unload. This means that you have to give circulatory support, but at the same time, you should at least try to reduce the stress, the worst stress, to the myocardium. So in principle, again, all the time. So LV unloading should be done, in my point of view, during ECMO all the time. Now, how? Because I know that many of you could have not access to Impella. You say, well, first of all, we just did several studies in the animals just to prove extensively and in details which is the best method to unload. And I mean, it's really clear that Impella is the most powerful left ventricular unloading and venting technique. Now, this is very important. So you should start immediately with ECMO with what I call left ventricular unloading directed management. So you don't have Impella, well, try at least to use non-invasive technique, like you should reduce the ECMO flow as much as you can. I mean, which means that the patient can stand the lower flow and lactate is still going down. So you do not have to use very high flow, because this means that the aortic valve will not open or will open in a very partial way, and this will distend the ventricle. So again, we studied extensively in animals comparing the Impella versus indirect drainage with a pulmonary artery. We studied recently the septostomy, and at the end, Impella worked out to be the most powerful and most effective way. But again, this should be done immediately. Don't wait the ventricle to be dilated. Don't wait for the smoke-like picture of the echo and looking at the very, very extensive stasis in the left ventricle before acting or reacting. Why running behind troubles? You should prevent. It's like leg ischemia. Don't wait for leg ischemia to put a perfusion. Do it right away. The same concept. Left ventricular unloading should be done in a non-invasive or invasive way from time zero. I don't know if you have the same idea. And I think that Professor Potapov showed clearly that the LV unloaded with Impella is really powerful, and you can use Impella to proceed after weaning from ECMO to again provide a prolonged support, and let's say to have a sort of soft landing after an aggressive therapy, which is ECMO, of course.
Yeah, I agree. I think earlier is certainly key. I think this is replicating the days when we started putting in LVADs, when we would wait till patients were on 3 inotropes, shock, arrhythmias, so we have to do it early. I think for this technology, it's a paradigm shift, and I think the key is recovery. And I think that in our data, we are recovering so many hearts. People are going home with their own hearts because of the ventricular unloading. So the key is you want to recover those hearts. Obviously, you want the patient to survive, but you want to do it with as little complications as possible. And that's why our strategy is ECpella if patients have RV failure or pulmonary edema, and then get the ECMO out as soon as possible. Our data now shows that we can get the ECMO out within a day or two. Then the patients are left with the 5.5, and then you have to decide what your end game is. If it's transplant, you leave the 5.5 in until transplant, or if it's recovery, we wean the weaning parameters, the way the Impella console is designed, it's designed for weaning. It's the first technology that we have where you could start weaning the Impella and see the EDP going up and the cardiac power output going down, and you say, hold off. You can't wean that patient. Versus LV EDP is stable, cardiac power output is going up, wean that patient, take the Impella out, and go to the next step.
Dr. Guess, you've sort of evolved your practice as you talked about with cardiogenic shock, and I know you have a few slides, so if we could cue up his slides, and love to have you present some of your data as well and what you're seeing in terms of recovery.
Sure. Okay, first slide. So again, we're a big ECMO center. We did anywhere from 50 to 100 ECMOs a year. So up until we got the 5.5, we had done 600 ECMOs with pretty good results. And then the 5.5 came up, and this was our first paper that we published. It was almost like a proof of concept. So this was our first series of ECpella with upfront 5.5 plus ECMO. 7 patients, really 1 died. The other one died. Everything was explanted. He died of monomorphic VT from his scar. 5 recovered and 1 was transplanted. The overall survival in our first cohort was 71%. And on the bottom, you could see the goal is to get them off inotropes, which we accomplished very quickly, and drive down their lactate for improving end organ perfusion. The next paper that we published, next slide please, was basically we changed our paradigm to get the ECMO out as soon as possible. So on the left, you see that in the old days, I'll call them the old days, 2 years ago, it would take 4 to 5 days to get ECMO out. Now that we put the 5.5 in along with ECMO, we're getting the ECMO out within 2 days. And I think that's a huge paradigm shift because you're avoiding, as you saw in the Dr. Potopo's slide, the risk of ECMO is ever present. It's not like you put the ECMO in, the risk is up front, and then it goes away day 2, 3, 4, and 5. It doesn't. The risk of ECMO is ever present as long as the ECMO is in place. Next slide, please. So this used to be our old strategy. Sky stage DE, shock, we go right to ECMO. Next slide, please. And now this is our new strategy. So on the left, when I reviewed all of our 600 ECMO patients, about 70% of the patients that went on ECMO could have had a 5.5 alone. So if we have a patient that comes in with LV failure from whatever etiology, we will go to 5.5 first and then bridge them to whatever end game they are heading for. If, however, they have pulmonary edema or biventricular failure in the middle of the slide, we go to ECpella with a 5.5 and then rapidly wean the ECMO to the 5.5 alone, and then they head to their ultimate destination. Next slide, please. So I've kind of coined the expression 5.5 first. These are the etiologies: acute MI, severe LV dysfunction, acute MR, ischemic cardiomyopathy, and never happens in our institution, but post-cardiotomy syndrome. Next slide, please. So this is our volume, and as I said, we do about 50 to 100 ECMOs a year. We're projected to do 25 5s and much less ECMO. Next slide, please. These were the indications: acute coronary syndrome, acute decompensated heart failure, and post-cardiotomy syndrome. Those were transfers into our institution. Next slide, please. And these are the outcomes. I think there's 2 very important numbers here. The overall survival was 85%. If you look at the Apache 2 score for stage D and E acute shock, the survival should be around 20%. So the overall survival is 85%, but the most important thing on this slide is recovery. 46% of patients recovered, went home with their own hearts. And that speaks to what we're talking about today. You have to unload the heart early and as aggressively as possible, and that will lead to recovery. Next slide, please. Thanks for your attention. I want to just thank my fellow Jim Hagan for preparing those slides.
Dr. Guest, could you also comment, you've had a unique approach to how you manage the flows across the two devices. So once the 5.5 goes in a patient that's also on VA ECMO, how do you flow balance the two devices to get them off ECMO rapidly?
That's a great question. So it's very, again, with the technology that Abiomed has, it's very simple. We just, wean down, as soon as we get organ recovery, if it's ECpella, meaning lactate's down, the patients are making urine, LFTs are coming down, and that could happen within hours with the ECpella strategy. We just start revving down the RPNs on the ECMO and slowly increasing the flow on the Impella. It's very simplistic. And I think, again, the key is the Impella technology, the fact that you could actually visually see the EDP going up. That's a unique technology and tool for the Impella wean.
Yeah, if I may add a comment. Maybe some of you watched and saw my presentation yesterday. As I said, at the very beginning of my career, the treatment of cardiogenic shock with ECMO was just putting a venous and arterial cannula and just pray. I think now the situation is a little bit different. We have a lot of possibilities, new options, new devices, particularly the combination of devices. And why is so important? Because you have to treat the patient and not make the patient fitting your technique or your approach. You have to modify your approach according to the type of patients, the etiology of a cardiogenic shock or whatever, how the hemodynamics of the patient changes. And sometimes you are absolutely not forced, but you should modify your approach according how the patient course or disease course is going. And this is very important. That's the reason why Impella now for us is really a big weapon in our hands, because we can really treat different ways, in the different ways, the patient. And I think ECpella, I mean, Professor Potapov was the one who made the name ECmella, and I think that is a tremendous advancement in the patient treatment, because you avoid aortic root stasis, you avoid ventricular and left atrium stasis, and you can, as Professor Gass said, you can also plan a very quick ECMO weaning, maintaining what is really important for a while, patient support. I made a study, I call it the ECMO gap, which is the death rate of patients weaned successfully from ECMO but still dying in the hospital. And in many series, this rate goes from 15 to 25%. So 25% of patients die in hospital despite a successful ECMO weaning. So I think we should be really more careful how to handle these patients. These patients are still very delicate. Therefore, I think, as I said before, a soft landing most of the time is needed. You have to treat them really in a careful way. And I think this combination of devices allows us to really modulate and attenuate the weaning and the passage from full support to no support. I think this is also a very important concept.
So I have two comments. First, I am really astonished how our approach similar is, and how the results similar are. For example, the time to remove SLS in our ECmella 2.2 plus is in median 2 days. So it was for me really difficult to make a picture of the patient sitting or staying close to the bed with ECmella with all devices in situ, because I removed SLS before the patient's extubated after 2 days. And it is really fast. It was really, for me, amazing. Second point about weaning. So we do wean SLS over Impella always now. And the criteria is very easy. So the criteria to for de-escalation to remove SLS, it's no inotropic support at all. So then if we achieve this state, we remove SLS. And of course, if the right ventricle do work. The second winning from Impella is also in the same stage and no inotropic support, and then ejection fraction should be over 30. If it's ejection fraction below 25, we speak to the patient and decide about next treatment, mostly LVED, durable LVED. Between 25 and 30, it's very difficult. So we perform additional studies, von Ganz catheter, all the echocardiography, very dedicated and very sophisticated studies, and then decide to remove or not to remove. But this combination allows us really tailor our therapy to particular patient.
I think we're coming up close on time, but I wanted to open up the floor and see if you had any questions for the panelists from the audience. Dr. Potapov, I just will pose one question to you. Something we've talked about is that I know you've been extensively using this approach in getting patients from a shock state to durable VAD. Can you just briefly comment on the use of this device that you've used as a bridge to durable VAD? Oh, I'm sorry. First, we do have a question from the audience. Sorry. Go ahead, please.
Thank you very much again for sharing valuable experiences. I have a question. Patients with the severe biventricular failure, cardiogenic shock due to myocarditis, and patients with VT storm. Those patients, we may hesitate to put Impella in because that can induce more VT, or some patients I heard did well with this combination. Please tell us your experience on those patients.
I think the ECpella, it is ideal combination for these patients because as soon as ECpella is in, you don't worry about a storm, electrical storm, because it is biventricular support. And so you can do to ablation and ablate, or you just wait, it's gone because of ischemia, acute myocardial infarction. So you can treat it accordingly to the etiology, or just wait and if it's acute myocardial infarction and going from the scar. So, but ECpella is the ideal tool. Regarding biventricular failure, it is mostly actually left ventricular failure with subsequent right ventricular failure due to a high afterload for the right ventricle, lung edema, and so on and so on. So if you unload the left ventricle with Impella, you treat right ventricular failure. We speak about standard patients. I do not speak about Eisenmenger or pulmonary severe fixed pulmonary hypertension or pulmonary embolism. I speak about just normal patients with dilative cardiomyopathy who develops biventricular failure. In majority of the cases, after unloading on Impella, the right ventricle recovers up to 90% of the patients, and allows you to implant after 1-2 weeks of preconditioning on Impella durable LVAD.
I just want to make a comment. Just one side comment on what you said about ventricular tachycardia in the 5.5. We put in a lot of them now. We haven't seen one case of VT caused by the Impella. I think now the 5.5 has multiple, it's stiffer, it doesn't migrate, and once you put it in, it stays in that position. We have not yet seen VT. It's an excellent question, but we just haven't seen it.
Maybe I comment on this. Unfortunately, in Berlin, we have seen a migration. We are not that good as in US. So we have seen migration, we have seen VT, but even on 5.5 and VT, the Impella 5.5 maintain output up to 4 to 5 liters. So it's very easy to treat these patients even in the VT. So it's not a big deal. If the patient's on VT, he is alive and can be treated accordingly. It's not a CPR immediate, not at all.
I think the question was also very important to underline another aspect, which is, again, we are lucky now enough to have dedicated tools for right ventricular support. In the past, I mean, VA ECMO was the only way to approach or durable devices. I mean long term. Now we have also Impella RP, which can be just a dedicated right ventricular support in case you have, let's say, very important improvement of left ventricle, but you still have some right ventricular dysfunction. Then now we can really address, as I said before, according to the type of patient, according to the type of disease, according to the hemodynamic condition, we can decide which is the best tool, and we have many options in our hands. So this is really, I think, an interesting time because we can treat much better our patient, again, focusing on the type of intervention we can do. So we have many weapons in our hands. That's really important. And Impella RP is one of them, for sure.
I think we're at time, so I want to, my sincere thanks to our speakers today for a great discussion, and thanks to all of you for attending.